So thanks for presenting this case. This is a 50-year-old male who complains of a fibular fracture and possible ligament damage from a skiing accident sustained on almost a week to 10 days ago. And let's take a look. There were a bunch of findings that have occurred here. There's fractures, there's sprains of the anterior talo, grade 3 anterior inferior talo, grade 1 to 2 deltoid tendinosis. So let's take a look together and assess what we can so we can go to collective minds. We loaded up the case, and I'm going to just start with the axial images. I like to go through the entire case axially. A lot of times I'll start axially. It's where I'll begin, and then I'll find my findings and use it. I'll use my template. So rather than just jumping into the case, it's important that we have a system to report. If you join my school on RadPod Squad by looking at radpodsquad.com, you can get towards joining. You'll see that under my classroom, I've created an MRI ankle, and I'm heavy-dutifully adding to it every day. I've got a whole video on how I evaluate it, but the money is really on this reporting template where you're going to go through all of these structures over and over again in a certain methodical way so that you're going to be able to come up with all the diagnoses just like I have. And I've broken that into different ways, and I can show you a variety of those. But let's just take a look at this particular case and apply our normal ankle report. I'll read the whole case for you so you get how I would approach it. So I'm going to just dive in. I see that there are things, but I don't get myself distracted. I'm going to go to my posterior tibial tendon, and I'm seeing that it's about twice the size of my flexor dig. So there is some degree of tendinosis of the posterior tibial tendon. There is an os navicularis, and then the majority is going to go, the second 50% is going to go to attach on the undersurfaces of the metatarsals, and we can see it as it comes down. 50% attaches on the navicula, and then other branches are going to go on to serve on the undersurface of the arch towards the cuneiform and metatarsal attachments. Moving back to my axial imaging, flexor dig, flexor hallucis, I can follow those guys down. And what I'm interested in understanding, is there a great degree of tenosynovitis? Not so much. I'm going to go to my tarsal tunnel. My posterior tarsal tunnel has my nerve, artery, and vein. Interested in looking to see if I have any masses there. I'm going to be looking to see whether or not I have muscular atrophy. I do see some fatty streaks here. Let me see about that on coronal imaging if I really believe that. And I have some mild fatty streaks in my quadratus plantae, my abducted digiti minimi, but very mild. I don't feel that I have enough at this point to invoke anything more than that, but I'll come back to that. I do see more fatty streaks along the forefoot. This may be someone who's developing some degree of neuropathy underneath what we see here, but I'll leave that for now. We're going to go back to our axials. I like the proton density, and we're going to move now to the peroneal tendons. I'm looking at the brevis and the longus, noticing that the brevis is slightly medialized, zooming in on that. And what we can see is that it's medialized, and there's this portion of it, and I'm going to take a look at my inframalleolar region here where these two pieces have to come together. I see a slight split, and then moving to join a common tendon, again, splitting here. One of the places I'm going to want to look at that is going to be a coronal image to understand. There's my medialized peroneus brevis. It's rejoining here at the inframalleolar groove with tendinosis. It's larger, and then to its insertion with a small split at the insertion itself. Going back to those axial images again now, I can appreciate my peroneus longus with tendinosis as it moves towards the cuboid tunnel. Magic angle is limiting me there. Let me see what I can see on lateral sagittal imaging, and I can appreciate here's my longus. It has some kind of elevated signal intensity in the inframalleolar region. And then, of course, going to this, let's take a look on STIR. Now, this is a great place where STIR will help me to understand, are those signals true that I can see? And I do find that there is some degree of mild tendinosis of my peroneus longus, but the majority of what I'm seeing there would be on the order of some magic angle phenomenon. So moving back to my peroneal tendons, I want to assess the superior peroneal retinaculum. And also, is there an accessory muscle here? We do not usually have muscle belly at the level of the lateral malleolus. So this is two choices, either an accessory peroneus quartus or an accessory peroneus brevis, or both. And so what I see is that there may be a small tendon that's attaching to actually the lateral side of the calcaneus. I would say that there's a quartus here, and there's also a low-lying brevis. So there's actually both features here of what I'm seeing for that. Superior peroneal retinaculum itself, I want to get to my proton density because I really want to understand that this is irregular and sprained with edema. So it may have subluxed, and there is maybe a small pouch. One thing I can use to work that out would be dynamic testing with ultrasound. I can place my transducer here, ask the patient to point their great toe down and out, and that will evert. And if there is a propensity for these guys to sublux, they'll sublux. But I can see that there is some tear of the superior peroneal retinaculum as it attaches on the fibula. Of course, we see the fracture. We're going to avoid that for now. Move on to our extensor tendons, and I can see some extensor digitorum tenosynovitis, and the muscle itself is looking good. No edema or atrophy there. Let's go to my ligaments now. I like to look at my deltoid ligament in the coronal plane, and what I can see is that it's wavy and irregular. And in fact, there is some kind of high signal at the lower shelf of the medial malleolus. Let's take a look at that on STIR imaging. We have a STIR here, and we can appreciate the thickened fibers. I can see the mild sprain and partial tear of the anterior deep deltoid as it attaches on the medial malleolus. I'm going to go back to my coronal images here and see this sprain that's occurring here and even some low-grade partial tear there. Let's take a look at that on T1 weighted images and appreciate the small enthesopathy that's occurring here. And the fact is I don't see much edema, but I see deep deltoid partial tear. Moving to the superficial deltoid, I want to see that on an axial image because I like to look at the superficial deltoid here, and I'm not seeing a nice black band of that superficial deltoid. It's sprained, slightly thickened, and the next thing I'm going to do is look for this fibers to come towards my tibiospring. That's the tibiospring component of the superficial deltoid, poorly defined, irregular, partially torn. Looking at that on STIR, what I can see here is in this region of my superficial deltoid, as I move towards the region of the spring ligament, it's thickened and just looks like a matted together group of fibers here. So definitely have some superficial deltoid partial tear at the tibiospring. The supromedial spring ligament is thickened. I can see that here, quite thickened. It's probably on the order of 3 or 4 millimeters here. And then looking at my medial plantar and inferior plantar bands, they look pretty good. Let me take a look here on the head. I can see actually they look a bit sprained here. Let's take a look at that on the T1 weighted images and understand that might be a fake out of the proton density imaging. But nonetheless, I do not see a tear there, but I do see a partial tear of the deep deltoid and a partial tear of the tibiospring and thickening of the supromedial spring ligament. Let's turn to the lateral ligaments. This is important here. We're going to go as far up as we can go and understand we have an interosseous membrane that comes to an interosseous ligament that then joins the posterior tibiofibular ligament. And what I can see here is that there's sprain and poor definition in this region, and then there's a fracture of my fibula. This fracture is intersyndesmotic. It's occurring through the level of the syndesmosis. There's a tear of my posterior inferior tibiofibular ligament. Looking anteriorly, this is poorly defined. I can see that there are some fibers that might be intact, so there's a high-grade partial tear. That's the way I would call that. I'm going to look at that on STIR to see what I can see of this. And what I can appreciate is that these posterior syndesmotic ligaments may be partially attached to this, but the fact that it's fractured through is the equivalent of having that torn. So there's this sprain of the posterior inferior tibiofibular ligaments and partial tear and fracture. So that's an effective fracture or ligament tear equivalent. Anteriorly, I do not see nice normal fibers of my anterior inferior tibiofibular ligament, and there actually seems to be some anterior subluxation of the lateral malleolus, an extra wrinkle. But let's take a look coronally and take a look at what we can see. What I want to see is 3 to 5 bands of small bands that are actually attaching here to my fibula. And what I can see is that there's a fracture right through this region. So that fracture, the lowest most portion of the syndesmosis, and then I go into my oblique Weber B type fracture. That's what that means because it's in the intersyndesmotic region. So I would say a partial tear of my lower syndesmosis. It's probably involving about 50% of the fibers, and a complete tear of my posterior syndesmosis. Moving down to the lateral collateral ligament complex, let's take a look at the ATFL. I see no ATFL. I see bulging of synovitis through that region. Maybe there's a part of the ligament there. Looking at the PTFL, I see sprain and synovitis. Let's take a look and see how that looks on STIR. STIR is always going to underestimate, sort of diminishes it, but nonetheless, when you have a full tear, I think it sees it very nicely at the fluid coming right through that complete tear of the anterior talofibular ligament, sprain of the posterior inferior talofibular ligament, and let's take a look at the calcaneofibular ligament. Let's go to the coronal image and see what we can see about that. The calcaneofibular ligament goes from the tip of the lateral malleolus, surrounds as a hammock underneath the peroneal tendons. Not seeing it very well there. Going to go back to my axial proton density. and see what I can find there of it. And I see torn. So grade 3 ATFL, I would say grade 3 CFL. It could be grade 2 to 3 CFL. I don't know that I'm seeing the tip of this well enough to appreciate that, but let me just, I don't find a normal calcaneofibular ligament. This little wisp isn't there. So grade 3 of both of those is my first thought on that. Moving to complete the exam after I'm done the ligaments, I want to understand my sinus tarsi, make sure that the fat is preserved in that location. I'm looking at the ropes of the ankle now, the Achilles. I always like to see that on a T2. I can appreciate that there's no significant Haglund or trace bursitis there. Looking at the plantar fascia itself, I can see that I don't have a tear of there. I do have some slight nodular thickening, which I was just about to say, but didn't want to overcall things here. But I see some subtle nodularity in this location. This is mild fibromatosis. It may indicate abnormal weight-bearing collagen or genetic predisposition to that. From that point on, let me get to my bones. Now we're talking about understanding this type of oblique fracture. This is a oblique intersyndesmotic fracture with, I would measure this, and the measurement is going to come out to 2 millimeters, probably, yeah. 2 millimeters of dorsal displacement of the lateral malleolus relative to proximal. Notice I have a posterior malleolar avulsion, and I have no medial malleolar avulsion, but I have ligament partial tears. So when I'm thinking about grading that whole complex, I'm going to be talking about supination external rotation injuries as a predictable sequence of events that travel in a circular fashion through the ankle. We can start with the anterior talofibular or anterior inferior talofibular ligament. We can then go to a stage 2 injury where we have an oblique intersyndesmotic fibular fracture. We can continue posteriorly through the posterior syndesmosis or a fracture of my posterior malleolus. And then, of course, stage 4 would be completing that with a deltoid injury. So right now, I have a solid SER stage 3 and going towards a stage 4. The thing that's holding me back from calling it a stage 4 is I really couldn't find a medial malleolar avulsion, but I do have a partial tear. So when I think about this entire thing and my impression, I would be talking about a supination external rotation SER 3/4 injury, and I would outline the features of the full thickness tears of the ligaments as I've described. And when I, just to help you learn more about this, if you start, you might want to just look at Radiopedia. What we're talking about is the Lauge Hansen or the Lauge Hansen classification. My French students will help me to the pronunciation, and or Duolingo. I have to spend more time. And what we're looking at, I think it really pays for a lot of radiologists to read over and over again the different stages of the supination external rotation, because it's the most common injury we've got. 40 to 70%, that's a big range. I would say a lot of injuries most of the time when I can describe them this way. And when I think about the stages, that's the anterior inferior tib fib ligament has to be torn. Then we're going to have a fracture of the fibula. The talus is going to displace. We have that fracture of the fibula. It can be an oblique or a spiral, just like we have here. Then we're going to tear our posterior inferior tibiofibular ligament, posterior malleolus, and then we're going to tear the deltoid or have a transverse fracture. And by far and away, I absolutely appreciate this radiology assistant, Frank Smithuis and Robin Smithuis from the Radiology Department of Amsterdam University Medical Center in Amsterdam. I cannot say enough for their open access education, for revolutionarily changing the way we think about these and helping so many of us to learn. When I first understood this 20 years ago, I struggled to move through this. And as I taught residents for many years, when these came out, I was thrilled. It really put it in perspective. It has videos of how the stages occur. But if we look at a Weber B injury and we think about the things that have to happen, they have this beautiful colored diagram of a Weber B injury. If you start with your anterior inferior tibiofibular ligament moving to your oblique fibular fracture, then they've got the lateral to show us our posterior malleolar stage 3, and stage 4 being a deltoid ligament injury. You know, anytime you're seeing a fibular fracture, you're going to invoke Weber B. Anytime you're seeing below the level of the intersyndesmotic region where all these guys are in place, the anterior inferior syndesmotic ligaments are intact, that's a Weber A. And again, I leave it, that's going to be usually a transverse direct blow this way. And then an oblique fracture is usually the exit trajectory of a force. And then, of course, Weber C, valgus type of injuries, we can see that transverse medial malleolar fracture and the stages of tearing the anterior inferior syndesmosis, and then the forces traveling up in a mesonerve or high ankle sprain fracture. And then, of course, completing the trajectory of the forces to a posterior malleolar fracture. So what I think here is worth your review, and I encourage you to look at it over and over again. It even shows you the stages, which is wonderful, just like we just spoke about. If we consider that the first stage is that anterior inferior syndesmotic tear, then the fracture of the fibula, then a posterior malfracture, and then a deltoid injury, you can appreciate the accuracy with which you can help your clinicians determine what exactly is the issue for this patient, what's the best treatment by staging it right from the MRI. So I hope that's been helpful. There is another avulsion down here. Let me just take a look at that. And that's part of my ATFL avulsion. Okay. Thank you for your time and attention. I appreciate it.